So this is where we start in the life cycle with this very young girl, and the questions that we have raised based on the scenario is, does she have this very common and very prevalent condition? In a very recent meta-analysis, the worldwide prevalence of PCOS was about 23% to 24%. Some of the more recent Indian studies have shown that this prevalence in the Indian population is twice the worldwide prevalence. It's 45% to 46%. So we have a much higher prevalence of PCOS in India. The reason we have included PCOS today is they are very high risk for prediabetes, diabetes, and the much more worried about metabolic syndrome. Now, what is the worldwide prevalence of metabolic syndrome in women with diabetes? Now, again, this number, lo and behold, is 25 to 28% worldwide. And anybody wants to take a guess for the Indian numbers? So depending on which literature you read right now, we have again twice as much, 45 to 50%, telling us that we are going to have a higher chance and a higher number of women with diabetes. So what are the criteria for diagnosing the PCOS? So truly, you actually don't even need a single blood test. PCOS is considered a clinical diagnosis. So you need a very high suspicion. So as you can see, we have several criteria: the NIH, the Rotterdam, and the Androgen Access Society. So hyperandrogenism, as Archana pointed out, irregular cycles, oligo or amenorrhea, and polycystic ovaries by ultrasound is not needed, as you can see by the Rotterdam criteria or the Androgen Access Society. So if you have a young girl who is in the age group, in the reproductive age group, we like to say, who complains of irregular cycles or hyperandrogenism, you can consider the diagnosis of PCOS. Now, this is very strongly linked to insulin resistance. I'm going to briefly just say that when we see them history and physical examination, using something we call the Ferryman-Galloway score for hirsutism scoring, and if they have a high score, then we send for certain tests of androgen excess. The total testosterone is routinely done, but these other tests that I have on the bottom right for you, the DHEAS as well as the 17-hydroxyprogesterone, are not done routinely for every patient unless they have a high hirsutism score. Very rarely do we screen for obesity with Cushing's, because we know that it's not as common as we would like to think. If they have amenorrhea for several months, certainly a prolactin, checking their thyroid, making sure they are not pregnant would be very simple things to do. And these are the tests that we have already been offered. So looking for dyslipidemia and HbA1c is important. Obesity is seen in almost 60% of patients, and hence it makes sense, obesity with insulin resistance being the main driver of the metabolic syndrome as well as PCOS, the management would definitely include weight management and other medications such as insulin sensitizers, and we'll get to that in a minute. So these are the most common things you see in PCOS women. You see obesity, you see irregular period, increased body hair, eventually which can lead to infertility and gestational diabetes. Okay. I already spoke to you about this. That's the reason I skipped the percentage values. So the PCOS management, I'm going to hand it over to Shilpa, because lifestyle changes matter a lot. In fact, I reflected today that all the lifestyle, the nodal room has been full all day, much more than even all our clinical talk. So it's interesting to see that the whole focus of our care is shifting, and we are very much interested in learning about lifestyle changes. Very often, we do need to give them short courses of birth control or oral contraceptive pills to regulate cycles. Metformin remains the gold standard of treatment as an insulin sensitizer, using anti-androgen drugs and others in combination to treat hyperandrogenism. So I will now hand it over to Shilpa. The reason you see three of us on stage is it's a multidisciplinary approach.